Hey y'all, it's Erin Piku, and I chose to do my master's project on ventricular fibrillation, or VFib. I chose to do my project on VFib not only because I'm interested in cardiology, but because it's one of the common causes of cardiac arrest, and as future clinicians, we'll have to be familiar with recognizing cardiac arrest and starting initial treatment in all areas of practice, whether that's in hospital practice or clinic. In this PowerPoint, we'll go over the general features of VFib, the assessment, diagnosis, and treatment of VFib, as well as quickly review the cardiac arrest treatment algorithm. So let's get started. So let's start by reviewing the pathophysiology of VFib. VFib occurs due to a malfunction of the cardiac conduction system. In the normal conduction pathway of the heart, the cardiac impulse is initiated in the SA node, where it then travels to the AV node, bundle of His, septal branches, and finally the Purkinje fibers. In VFib, there's a disruption of this pathway, which leads to uncoordinated ventricular depolarizations and contractions, where the ventricles essentially quiver instead of producing a coordinated contraction. When this happens, the patient goes into cardiac arrest, where the heart is unable to effectively pump blood throughout the body, leading to circulatory collapse and the potential for sudden cardiac death. VFib is one of the 4 causes of cardiac arrest, the other causes including PEA, or pulseless electrical activity, asystole, and pulseless V-tach. Overall, the most common risk factor of VFib is ischemic heart disease, or MI. Some other possible risk factors for VFib include structural heart diseases, cardiomyopathies, other primary cardiac arrhythmias, electrolyte abnormalities, and drug-induced VFib. Symptoms will be immediate with the onset of VFib. Patients in VFib will present with a sudden loss of consciousness and collapse. On physical exam, the patient will be pulseless and unresponsive. And the differential diagnoses for a patient presenting unresponsive in cardiac arrest include the 4 causes of cardiac arrest mentioned previously. Those including PEA, asystole, pulseless V-tach, and VFib. Definitive diagnosis is ultimately made by EKG and will guide the ACLS treatment algorithm. So diagnosis is made by EKG. The EKG will show no identifiable waveforms and is commonly described as having a bizarre bag of worms appearance with a rate between 350 to 450 beats per minute. After the patient is stabilized, additional laboratory testing and imaging, including cardiac enzymes, a CMP, thyroid function panel, tox screen, coronary angiography, chest X-ray, and echo should be obtained to determine possible underlying causes of the VFib. Really, early recognition and intervention are key for effective treatment of VFib and more favorable patient outcomes. After finding a patient unresponsive, CPR should be immediately started at a rate of 100 to 120 compressions per minute in cycles of 30 chest compressions followed by 2 rescue breaths. Correct hand placement and compression depths for different age groups are shown in the figure here. Focusing on adult CPR compression technique, hands should be interlocked and placed mid-chest with a compression depth of 2 inches. It is also important to remember to allow a complete recoiling of the chest between compressions for effective CPR so that way the heart can properly fill with blood between each compression. Although CPR is the initial treatment for all forms of cardiac arrest, defibrillation is the definitive treatment of VFib. AED setup and placement should occur as soon as possible after CPR is started. After the AED is set up, a shock should be delivered if the rhythm assessment detects a shockable rhythm, such as VFib or pulseless V-tach. CPR should only be stopped temporarily during AED rhythm assessment or defibrillation, and of course if ROSC, or return of spontaneous circulation, is achieved with the return of a pulse. I wanted to briefly review the steps in the adult cardiac arrest treatment algorithm. As I mentioned on the previous slide, CPR followed by AED setup and placement should occur as soon as possible after a patient is found to be in cardiac arrest. If the AED detects a shockable rhythm, such as pulseless VTAC or VFib, a shock will be advised. After defibrillating and resuming CPR, cardiac rhythm should be rechecked every 2 minutes if ROSC is not achieved. If the second rhythm check continues to show VFib, an additional shock will be advised. If ROSC does not occur after a second defibrillation, IV epinephrine should be given every 3 to 5 minutes during CPR. And if ROSC does not occur after a third defibrillation attempt, amiodarone should be given. Throughout this presentation, we reviewed the assessment, diagnosis, and treatment of a patient in VFib. Being familiar with the cardiac arrest treatment algorithm and having access to a copy is important in all specialties and patient care settings. Survival rates of patients in VFib are inversely related to the number of defibrillations required to attain ROSC, meaning the more defibrillation attempts, the less likely a patient is to survive. That being said, high-quality CPR and timely defibrillation are crucial for more favorable patient outcomes following VFib. Here are a list of my references. Thank you for watching, and I hope you found this review helpful.